There's a whole pile of material on table 42. We've laid out a smorgasbord for you. My intent is to take nothing back in my suitcase with me. So please help me to lighten my load, if you would. And at the end of my time, on table 42 in the back are a whole series of wonderful measures and tools and publications from our school. I hope you will avail yourselves of it. You know, when you really boil it all away, what we're doing is, from this recent paper from our colleagues at the Institute for Healthcare Improvement, Don Berwick and Maureen Bisignano's shop in Cambridge, Massachusetts, what we're really doing, and I would argue where Providence needs to go, is we're creating a new measurement set to implement the triple aim, to implement what Berwick described more than a decade ago as the triple aim: great individual care, great outcome, and a reasonable cost. That's what we're trying to do. Now, I'm not saying we've got every measure down pat. A group your size and your scope, you could help move this field forward, move this ball down the field into the red zone ready to score as you create the appropriate population health measures. You've got those 13 or so community ministry boards at the local level. They're in the best position to really understand the needs in the local community. I see a great opportunity here to create new measures that really will look at the health of the population. Let's go back to Pennsylvania for a moment. So the Robert Wood Johnson Foundation, headquartered in Princeton, New Jersey, about 90 minutes from Philadelphia, using publicly available data in calendar year 12, did an amazing thing, and I want to tell you a little bit about it. And maybe tonight you'll go look up countyhealthrankings.org. So one more time, using publicly available data, socioeconomic status, hospitalization, mortality, education level, smoking rate, divorce rate, gun violence, big data. Crunching this big data, RWJ could rank the quality of life in all 70 counties in our great Commonwealth of Pennsylvania, which they did. So where do you think Philadelphia County, home of Jefferson and 4 other allopathic medical schools, 25 Joint Commission accredited hospitals in one county area, 1 out of 4 doctors passing through this county in the United States during her training, where did we end up in this statewide ranking? Well, you could probably guess, dead last. Dead last. So I have to ask the question, much to my own professional peril, if anybody tweets the provost, I'm in a lot of trouble. So in Philadelphia, as 3 helicopters from the 3 medical schools rushed to pick up accident victims on the highway, as 3 cardiac transplant centers struggled to make their volume numbers, as 3 National Cancer Institute research centers, 2 of which are 4 blocks apart, continue to spend billions a year on research, we're still ranked dead last in our state from a population health perspective. How are we going to reconcile this moving forward? That's our challenge. To me, that's what health reform is really all about. And that's your mission moving forward. It's an incredibly tough job. So we're going to need some big data crunching, hence a brand new journal. Did you know there's a journal called Big Data? It's amazing. I didn't make this up. Brand new. We're going to need that amazing centralized human resource center that you have. I was mesmerized by that video. You're going to have to crunch your own numbers. Why? Because your own employees are a population. So maybe one of the first places for Mike and the team to start is, hey, how fat are you? Who smokes among you? Who exercises here? I was in the exercise room this morning at 6 o'clock. It wasn't too crowded. I saw a couple of people sweating, but not nearly as many as are here right now. Let me show you what I mean by that. So, population health at the sort of visceral, local level. And for Rod, I want him to be thinking about a Providence accountable care organization while we answer this public question. Okay, here we go. So I want you to raise your hands and help me out. Annals of Internal Medicine, 2006, University of Michigan Social Science Research Center. What percentage of adult Americans in March 2013 do all 5 of these things? You got to do all 5. Well, number 5 will say, are close to an appropriate body mass index. We'll give you partial credit. So what percentage of grown-ups in our great country do all 5 of these things regularly? Raise your hand, help me out. 5%, I got a 5%, we got a 5%. Anybody else? 10, 10, 10, 10, we got a 10, we got a 10, we got a 5, we got a 5, we got a 10. This is like medical, unexplained variation. Here we go. One more guess, anybody? 1, skeptic, 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 okay. So, of course, the answer is 3%. So, Rod, you want these people in your accountable care organization? Do you want these people in your local community? Here's American culture. I want my Lipitor on the way to McDonald's. Part 2, you pay for the Lipitor, I'll pay for the Big Mac. Preferably when it's on sale. That's our culture. So population health has got to deal with all these messy issues, this 3%. Listen, even in the 21st century, we know that the key determinants of health are smoking, unhealthy diet, physical inactivity, and, of course, the centuries-old scourge of alcohol abuse. This is where it's at from a population health perspective. It's not the new Da Vinci robot. Oh, them's fighting words. It's not the new 30 new ICU beds. It's all about these 4 key behavior changes that we have to implement, for which most physicians, including yours truly, and John and Rod, I would submit, had no formal medical school or residency-based training in any way to attack these problems, unless you went and got a special degree at a school of population health. So this is a big challenge for us. You all know from a public policy perspective, again, the policies and interventions. Our country devotes a modest amount of resources to studying the impact of chronic illness, as you could tell from this. And again, despite scores of billions of dollars, almost over 40 years, the #1 way we reduced cancer mortality was by a national attack on cigarette smoking. Yes, breaking the human genome and all of these wonderful discoveries. Who could argue with any of that? I get it. On the other hand, from a public policy, population health perspective, our biggest advance has been in smoking reduction, not cessation, but smoking reduction. So back to your vast workforce, what are the population health measures you might start to implement using your own centralized HR data set? This is a very exciting area. So now let me point out a couple of challenges, and then we'll move to part 3. So, a little hard to see in the back of the room. Let me set this up. And again, oh boy, if anybody's tweeting about this, I'm in huge trouble. So colleagues, this is a poster that was on the door of the Jefferson Medical College, our sister school, Department of Urology. And it says in blue print at the bottom, oppose U.S. government action to eliminate prostate cancer screening for all men. In other words, at the nation's largest private medical school, our wonderful sister school, Jefferson, in the academic department of urology, this poster appeared on their front door of their clinic. Now, in the middle of the night, I went and pulled this poster down, turned it into this PowerPoint, and then snuck back and put it back on the door. They have no idea you're seeing this right now. True story. So this is population health at an academic medical center. You agree we have a challenge? I mean, this is sending a schizophrenic teaching message. How about this? So in the AARP bulletin, which my wife and I now regrettably enjoy on a regular basis, this is a full-page ad in last March's, almost exactly a year ago, issue of the AARP bulletin. Now, for the non-clinicians in the room, let me explain what this advertisement is about. So it says, the power to fight advanced prostate cancer is already in you. Turn it on. So colleagues, this is an ad for a powerful new technology called Provenge, an amazing new product. $33,000 a dose, and you need 3 doses. Paid for by Medicare, and it extends life for metastatic prostate cancer victims who have no other therapy available, probably 4 to 6 months. So we have I would submit, a ethical and maybe even a religious dilemma. Who's paying for Provenge as advertised in the AARP? Answer, all of us, via our taxes to Medicare. Is this an appropriate resource allocation under a population health scenario moving forward? That's a key question I can't answer. You're going to have to answer. Okay, and to close out part 2, population health, here's a wonderful Newsweek story all about population health. Maybe you missed it last summer. One word that will save your life, and that one word is, please? No. Say it louder. No. No, I don't need that test. No, I don't need that cath. No, I don't need that endoscopy. I'm at more risk for having it than not. So we're going to have to take this cultural battleship and turn it around inside the Panama Canal. That's the visual analogy I'm making. Almost impossible to picture. But that's the challenge of population health and health reform. So now it's time to get to the third part of our time together. And I'm going to ask you a couple of questions. So are we at the tipping point? Are we really ready to sort of tackle all of this? Well, you know, obviously, I care a lot about this for all kinds of reasons, as do you. So this is an updated picture of my family. And I can't talk about reform without thinking about the family, just like you. So there's my physician wife, Esther, and my fraternal twin daughters, Leah and Rachel, on either side, my son, Jacob. So we've got Leah, Jacob, Esther, David, and Rachel, the entire Old Testament pinned down. Colleagues, I know you're a sensitive group, but I'm sure you'll appreciate. So my 10 years on the board at Catholic Health Partners, I contributed to board diversity. So, Leah and Rachel, they're 25 years old. They live together in Arlington, Virginia. Rachel's in her 3rd year of medical school at George Washington University. Leah is finishing her master's degree in public health at George Washington. My son's a senior at George Washington. They all colluded to go to the most expensive school in the United States. We have no other connection. There ought to be a big dormitory named after the Nash family, but that's another story. So why is this important for today? Well, so Rachel's in her 3rd year of medical school. My wife and I are living vicariously through her to some extent. Right now, she's on her surgical rotation. So let me tell you 2 quick stories. When health reform was passed 2 years ago, Rachel was a 1st-year student, 3 blocks from the White House. My wife and I were pretty excited. Whatever your politics, certainly an amazing social event. So in March of 2010, now hard to believe, you know, almost 3 years ago, I called Rachel and I said, wow, how exciting. There you are, a brand new medical student, 3 blocks from the White House. What did you do today in school to talk about reform? And you could sort of hear over the phone, if you could hear eyes rolling into the back of her head, as though to say, Daddy, you know, we were too busy dissecting the foot for a week to have 1 hour set aside to talk about health reform. So that's a tactical reality. One more Rachel story, then I'll quit, because this is not HIPAA compliant, I realize. She's over 18, and I don't have her permission to tell you, so if anybody tells on me, I'm in a lot of trouble. So Rachel starts her medicine rotation. Now she's in her 3rd year. Her first day in a wonderful community hospital just outside our nation's capital. The doctors in the audience will resonate with this. Her brand new female attending in charge of the service comes onto the floor, never introduces herself, doesn't shake my daughter's hand, and proceeds to interrogate her about a patient's condition in front of the patient. It made my blood boil. This is March 2013. All the clinicians in the room, if you can resonate with this story, raise your hand. Right, everybody look. So is that the kind of doctor we want to train? Is that who you want taking care of you? Hence the picture of the children. Okay, finally, you recognize this other handsome guy? So who's that? Right. So Rod was nice enough to mention the 2 Wharton Awards. This is back in October in New York City. Details not important. Mehmet was the previous winner, so he had the obligation to hand me the trophy in New York City. Now, whatever your feelings about Mehmet's diet, you know, I get it. Keep it to yourself. But here's the power of social media, a great lesson in population health, and then we'll get to health reform. So Mehmet Oz has over 1 million Twitter followers. Over 1 million. Staggering. On the train ride home from New York City to our home in suburban Philadelphia, later this same night, my BlackBerry is having a seizure. It won't shut off. It seems to be buzzing nonstop. What had happened? Well, Mehmet's publicist had posted this and several other pictures for his Twitter followers, and I was getting sort of subsidiary email that went something like this. Is that you? Meaning, they're following Mehmet's every move, and then my little face pops up, so people who knew me, who also happen to be Mehmet Oz followers, were checking in with me after midnight. Don't you have anything better to do after midnight on a weeknight except check on Mehmet's whereabouts? So what's the take-home message? Pretty scary stuff. The power of social media. Just one more time, Leah and Rachel, I'm still trying to get friended by their Facebook page. I can't hack into it. So we've got a whole new world out there to be thinking about. Okay, time for health reform right on schedule. So basically, reform is built on a house of quality and safety, even though you've never heard even the President of the United States describe it this way. So my job in this part is to connect the dots very quickly. So there are 5 pillars to reform. Number 1, a national quality improvement strategy published in March 2011. I'll show you a picture of that. 60 new measures coming our way, both inpatient and outpatient, and Rod and the team know all about these. Value-based purchasing, where Medicare is going to try to transmogrify itself from bill payer to savvy shopper, pay for performance program, pay for results programs. Already, I'm sure you're a part of these. Prevention and wellness, scores of millions of new money into prevention and wellness. And then, of course, creation of new entities, the Center for Medicare Innovation, the Patient-Centered Outcome Research Institute. You get the idea. So let me show you what's under these pillars. Here's the National Quality Improvement Strategy. This ought to be mandatory reading for every board member. It's only 25 pages long. How the Uncle Sam is going to articulate all of the various agencies to promote the quality and safety agenda. Do no harm. Nothing about me without me. Here's the Hospital Engagement Network. I'm sure many of your Providence organizations are in a hospital engagement network like ours is, sharing information, benchmarking across the state, and in your situation, benchmarking across multiple states on care coordination, best practices, and all the rest. Here are some of the key components of the prevention and wellness agenda. I'm not going to read these in the interest of time, but the message is a lot more money being pumped into prevention and wellness. And that top line right there, eliminating cost sharing for covered preventative service, a fancy way of saying no co-payment for that Medicare patient colonoscopy, that Medicare patient mammography. This is pretty exciting stuff. However, who exactly is going to pay for all of this, still somewhat unclear. Important from a population health perspective for sure. But this is the key slide on our third part of our time together, looking at health reform from a change in the incentive process. So we're going to quickly describe each of the 4 boxes. Then I'm going to show you a picture of how we're going to implement each of the 4 boxes. Then we'll tie this all together in a nice knot linking population health and health reform. Box 1, tying payment to evidence and outcome. So volume is no longer the key goal. Value for the money spent. Outcome measurement, closure of the feedback loop, and transparency. So tying payment to evidence and outcome. I think with your data crunching capability across your varied system, you'll be able to promote this kind of thinking. I'm looking forward to hearing about that progress. Box 2, bundling payment, already alluded to by Mike Butler. Bundling payment for physician and hospital services, I'll show you that in a moment. That means we've got to sit in a big room like this and figure out how to divide up the pie. Box 3, reimbursement for care coordination. So for board members, it's not just what goes on within the four walls of the institution, it's what goes on the outside that might be even more compelling. And then box 4, this amazing new thing, the Accountable Care Organization. By the way, do you know what ACO really stands for? Awesome Consulting Opportunity. And I'm sure Dick Umdenstock will have a lot more to say about ACO, so I don't want to steal his thunder, for sure not. So we're going to move from left to right, no politics intended here. And for the clinicians in the room, nurses, doctors, and others, this means as we go from left to right, we're going to be bearing more economic risk. In other words, every clinical decision will have an economic consequence. The days of this is how we do it here aren't going to fly. This is how we do it here based on good evidence because we've measured what works at Providence and what doesn't. That's the cultural change. So part 1, we've got pay for performance, never events. Now you know we still have a problem, so one more time, front page USA Today. By the way, do you know where this comes from? Of course, it's from an article in the journal Surgery from last month that pointed out, I know you won't believe it, 80 wrong site surgeries in our country every week throughout 2012. That's right. That's what's reported to the Joint Commission. And that's what this article in the journal Surgery leading to today's piece, March 8, 2013. Staggering. Staggering. How could this be true in the modern era with a checklist? Well, so that's why we have never events, because Medicare now won't pay us when we make a big boo-boo like that. Moving to the right some more. Here's this episode of care. So I already alluded to the fact, a single payment. So let's say today's Friday. So on Monday, across Providence, all patients with congestive heart failure, the system will receive a bundled payment. Wow. What would we have to do as leaders this weekend to prepare for a bundled payment reality? Well, we'd have to know a lot. We'd have to know who cares for patients with heart failure, what's the best evidence, what's the benchmark. We'd have to give that information back to the nurses and doctors and pharmacists at the bedside. We'd have to know our marginal cost. We'd have to figure out where's the most efficient hospital to treat these